are a paramedic trained in Pediatric Advanced Life Support. You are working in the Pediatric Emergency Department when a mother brings her 9-year-old daughter into the ED. In triage, the child is listless and breathing at 32 times per minute. You move her into a treatment room and take vital signs. Her pulse is 50, blood pressure is 68/38, and respirations are rapid and shallow. The mother denies any history of cardiac problems. You start oxygen at 100% via a non-rebreather mask. You attach a cardiac monitor and see this rhythm. 1. You recognize this rhythm as A. Sinus bradycardia, B. Regular sinus rhythm, C. Junctional escape rhythm, D. Agonal rhythm. Correct answer, A. Sinus bradycardia. This rhythm looks like a regular sinus rhythm, but the rate is less than 60 per minute. There is one P wave for every QRS. PRI and QRS are normal. 2. Your primary goal in this scenario is to A. Obtain IV/IO access, B. Treat the hypotension, C. Identify and treat the cause of the bradycardia, D. Implement therapeutic hypothermia. Correct answer, C. Identify and treat the underlying cause of the bradycardia. Bradycardia in a child, when the patient has signs and symptoms, indicate that the child is critically ill. You quickly assess the child for signs and symptoms that accompany her bradycardia. At the same time, a team member establishes an IV site while another provides PPV to the child. 3. Significant signs and symptoms of poor perfusion with bradycardia include all of the following except A. Respiratory distress, B. Hypertension, C. Decreased level of consciousness, D. Faintness and dizziness. Correct answer, B. Hypertension. In symptomatic bradycardia, the clinical finding typically will be hypotension, although the child might be normotensive. You note that the team member is delivering effective ventilations, as evidenced by good chest rise and oxygen saturation of 94%. You determine that the child has significant cardiopulmonary compromise and poor perfusion, despite adequate oxygenation and ventilation. 4. The appropriate next step is to A. Begin CPR, B. Ensure an adequate airway, C. Consult a pediatric intensivist, D. Administer epinephrine. Correct answer, A. Begin CPR. The poor perfusion and heart rate less than 60 beats per minute means that the brain and heart are not receiving adequate oxygen. The team should begin CPR. After 2 minutes of high-quality CPR, you ask the team to pause compressions. You see this rhythm on the cardiac monitor. 5. The appropriate next step is to A. Begin CPR, B. Ensure an adequate airway, C. Administer atropine, D. Administer epinephrine. Correct answer, D. Administer epinephrine. Epinephrine can cause increased heart rate and contractility. Although atropine is an option, epinephrine is the best choice in this scenario. 6. The correct dose of IV epinephrine is A. 0.1 milliliters per kilogram of 1 milligram per milliliter, 1 to 1,000 concentration. B. 0.1 milliliter per kilogram of 0.1 milligram per milliliter, 1 to 10,000 concentration. C. 1 milliliter per kilogram of 1 milligram per milliliter, 1 to 1,000 concentration. D. 1 milliliter per kilogram of 0.1 milligram per milliliter, 1 to 10,000 concentration. Correct answer, B. 0.1 milliliter per kilogram of 0.1 milligram per milliliter, 1 to 10,000 concentration. The 1 to 1,000 concentration should not be used in any cardiac arrest situation. 7. Give epinephrine. A. As a one-time dose only. B. Every 3 to 5 minutes for a total of 3 doses. C. Every 3 to 5 minutes to a total of 10 milligrams. D. Every 3 to 5 minutes with no dose limitation. Correct answer, D. Every 3 to 5 minutes with no dose limitation. After repeat doses of epinephrine, you do not notice a significant increase in heart rate. 8. At this time, you should consider all of the following except A. Stop resuscitation efforts. B. Transcutaneous pacing. C. Administer atropine. D. Search for and treat reversible causes. Correct answer, A. Stop resuscitation efforts. There are no reliable predictors of outcome to guide when to terminate resuscitative efforts in children. Clinical variables associated with survival include duration of CPR, the number of doses of epinephrine administered, age, witnessed versus unwitnessed cardiac arrest, and the initial and subsequent rhythms. However, the clinician should be aware that none of these associations predict outcome. You direct the team to prepare for transcutaneous pacing of the child. The pacemaker is applied, and the child's heart rate increases to the paced rate. You direct the team to prepare to transport the child to the pediatric ICU, where a pediatric cardiologist is waiting for her arrival.